something else, and not for multi-drug resistance.
Thank you, sir.
Anyway,
Yes.
just I'm not able to allow the screen. Just allow. How much time we have?
Almost an hour and more, sir. It's not an issue, sir. For guest lectures, we keep there's no time limit. Depends upon how the lecture goes.
Okay. Am I audible?
Yes, sir. The slides are also visible. You're audible as well.
Thank you. Thank you, everyone, for joining this late hour. And what I will do is I will cover two topics. One is antibiotic treatment of neonatal sepsis, in which I will cover the how to frame an antibiotic policy. I think that's important for any NICU. We need to have an antibiotic policy. So I will briefly touch upon what are the principles, what are the methods by which you frame an antibiotic policy for for your unit, for example. And that's the first part. And the second part is how to establish an antimicrobial stewardship program in the NICU. And that are the two topics which I would be covering. And I will try to cover each topic in about half an hour, and then we can have discussions at the end of both the talks or at the end of each talk, depending upon your preferences. The first is the antibiotic treatment of sepsis. And as usual, I will start with the prologue before we started the topic. This is actually a treatment chart, nothing to do with which state it's from, or whether it's a private or as a government. We'll not go into that. We'll just look at the treatment chart of a baby who is being treated in the NICU for possible sepsis. This baby is receiving Iptas, meropenem, metronidazole, amikacin, colistin, fluconazole, and on top of that, the baby is also receiving IVIG, which has no role in the treatment of sepsis. And that's unfortunately the situation in many units. We just don't know how to use antibiotics. As a neonatologist, I would always want you to be good clinicians. We should not become good antibioticologists. We are not here only to treat babies with antibiotics. We are there to treat babies. That's the message I want to give, that antibiotics is not the panacea for everything. Anything the baby is throwing up, we just add an antibiotic. That's not the case. It should not be the case. So when I presented this in some meeting, then they asked, "Sir, where is vancomycin?" So I thought, actually, there was another treatment sheet. This next page that had vancomycin and other things as well. So we'll not go into that. But that's how many people end up treating sepsis. And what's the big problem if you treat sepsis, like whatever you have? What is the big deal? So this is actually a elegant article. Those who are interested in sepsis and antimicrobial resistance, you should read this article. This was published by the AIIMS Antimicrobial Resistance Collaborator Group, published in Lancet in 2022. And these are actually global deaths. They estimated the number of global deaths that can be attributed to antimicrobial resistance or associated with antimicrobial resistance. So these two are two different terms. So attributable means directly you can attribute that death to that cause. And association means you have an association. So there is some bug that was resistant, but the child, an adult, or a baby died because of some other reason. So that's association. So here we are looking. These are not newborn deaths. These are any age group. You have newborn children and adults and so on. And if you look at this graph, on the x-axis, we have different organisms. We have E. coli, Staph aureus, Klebsiella, Strep pneumonia, and so on and so forth. On the y-axis, we have the number of deaths. And there are two different, it's a component bar chart. So there are two different bars. That's two bars within a bar. And the light colored one is associated with the AMR. So we'll not go into that. But just we'll look at the dot ones, the dot bars, which are actually the deaths that can be attributed to antimicrobial resistance. And if you look at, for example, if you look at E. coli, you can say that roughly about 250,000 deaths, in other words, 2.5 lakh deaths globally across all age groups are attributed to a resistant E. coli bug. And that's the number we're talking about. And if we take all these deaths that could be attributed to antimicrobial resistance, we have 1.3 million deaths globally across all age groups that could be just attributed to antimicrobial resistance. That's huge, 1.3 million deaths, of which only six pathogens, E. coli, Staph aureus, Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter, and Pseudomonas. These are six organisms. These six organisms, they contribute to zero point 0.9 million or 9.2 lakh deaths globally. Six organisms, resistant organisms, just because of antimicrobial resistance, these bugs, they contribute to 9.2 lakh deaths. And that's a magnitude which you're talking about. And this is quite old now. This was a review done by agency in the UK based on the recommendation by the Prime Minister. They set up a scientific committee. The government set up of that time set up a scientific committee, and they reviewed the antimicrobial resistance and its burden. And what they found was the deaths attributable to antimicrobial resistance every year compared to other causes of death by 2050, that is in another just 25 years, antimicrobial resistance alone would result in 10 million deaths annually. And that will surpass anything other than, by that time, this deaths due to antimicrobial resistance will surpass deaths due to cancer, due to diabetes, due to diarrheal illness, and so on and so forth. And that's going to be the number one cause by 2050 if we don't do anything now. And that's the magnitude which we're talking about. We are talking about the deaths that could be attributed to resistance. And we are talking in terms of millions of deaths, of course, across all age groups. And we just can't escape from antimicrobial resistance. If it's not there in your unit now, make sure that it doesn't happen in the next 10 years. And if it is already there, then take steps to control, to curb antimicrobial resistance. That's the premise of my talk. So what I'm going to do is I would just talk about how to frame an antibiotic policy. For that, we'll talk about these answers questions. So we'll try to answer these questions. First, why we need an antibiotic policy. And of course, that's important for my next talk is antimicrobial stewardship. And what is an antibiotic policy? So what actual policy should be? How to determine or how to decide the optimal regime for a particular unit? And what is the evidence? Is there any evidence that this early onset sepsis is the particular regime which should be used? Late onset sepsis, this is the regime used. And term neonates, preterm neonates, pneumonia, and so on and so forth. Is there any evidence? And if there is no evidence, then there are any international or national guidelines which we have. So what is actually the existing policy? And how to frame an antibiotic policy for a particular unit. So we'll try to answer what, why, and finally, we'll talk about how. So how, I'll talk about how to decide an empirical initial antibiotic policy. Because when you suspect a baby to have sepsis, then you do not know which organism that baby is going to grow. The culture report might come after 48 hours, 72 hours, and in some units it might come after 7 days. So you have to start the baby antibiotic, but you cannot wait for 7 days to start antibiotics. So that is the empirical antibiotics, the initial antibiotics. Then once you get the culture reports, then you can titrate based on the culture reports, what bug you got. So gram negative, then you can stop vancomycin, for example, how to titrate the treatment. And lastly, I will talk about multi-drug resistant issues. Most units are grappling with this issue of multi-drug resistant organisms. So how we are to treat multi-drug and pan-drug or extremely drug resistant organisms. I'll just have a few slides on that. The first question which we're going to answer is why we need an antibiotic policy. In my premise itself, I talked about the deaths due to antimicrobial resistance, but let us look at it in a much granular way. we look at the burden of antimicrobial resistance in newborns, particularly in India. And this is the Dennis collaboration study. This most of you must have heard about it at least. DENI stands for Delhi Neonatal Infection Study Collaboration. And the study was done between 2010 and 2014, and the results were published in the Lancet Global Health in 2016. And it had 4 hospitals. The major hospitals were Safdarjung, Maulana Medical College, and Chacha Nehru Barshipitsalia, and I forgot the 4th one, which is, of course, AIIMS. Sorry. And the if you look at the AMR pattern, the antimicrobial resistance pattern of the organisms which are isolated in the DENIS, and here we have on the x-axis we have the different organisms, and the y-axis we have the proportion of the organisms that are resistant to a particular drug class. For example, if you look at Klebsiella, we'll talk about multi-drug resistant. Multi-drug resistant. I will talk about the definition of multi-drug resistant in the subsequent slides. Let us just look at the burden now. You can see that about more than 50%, or more than half of all the Klebsiella isolates were multi-drug resistant, and about more than 1/3 were carbapenem resistant. And when you talk about Acinetobacter, they are much more resistant than Klebsiella and any other organism. More than 80% of Acinetobacter isolates were multi-drug resistant, and about 80% were carbapenem resistant, that is meropenem resistant. E. coli is, if you can, it's a slightly better child to rear. So E. coli is multi-drug resistance only about 40%, and carbapenem resistance only about 15.3%. And if you look at the gram-positive organisms, an equivalent, you can sort of equate multi-drug resistance with vancomycin resistance. So Staph aureus, if you look at Staph aureus, methicillin resistance we can equate sort of with multi-drug resistance for gram-negative. So here, Coagulus negative staphylococci, we have about 60% are methicillin resistant. That means you don't have any other choice than to use vancomycin. And Staph aureus, about 40% are resistant to methicillin. Again, you have to resort to vancomycin. And fortunately, there's no vancomycin resistant staph till now. We have Visa, there is vancomycin intermediate, but usually we do not have vancomycin resistant staph in our country. And if you look at enterococci, and 1/4 of enterococci are vancomycin resistant. That means you need to resort to something else, like linezolid. So that's roughly the pattern which we observed in the Delhi Neonatal Infection Study Collaboration. And these are babies who are born and admitted into these hospitals. So the inborn cohort. And if you look at the outborn cohort, the babies who are born at home or who are born at some other facility and then came to a tertiary hospital, there this is ominous. If you look at Klebsiella, 80% are multi-drug resistant. Acinetobacter, 90% are multi-drug resistant. E. coli, more than 56% are multi-drug resistant. And Staph, about 90% are methicillin resistant. Staph epidermidis. And Staph aureus is slightly better, about 30 to 40% methicillin resistant. So vancomycin resistant enterococci is about 40%. So we're looking at very high proportions, like alarmingly high proportion of antimicrobial resistant bugs in these babies. Of course, this is not. Of course, this pattern was not seen in AIIMS. There were inter-unit differences, so we cannot generalize. But in general, we have to be aware of the fact that there are some units in which the antimicrobial resistance is so high. And what about these are tertiary hospitals? All of 4 of these hospitals are tertiary hospitals. So what about district hospitals, the secondary level hospitals, or what we call special care newborn units, or SMCUs? What about these hospitals? So if you look at multi-drug resistant special care newborn units, this is just now we published a study in Lancet Global Health in 2020. Just if I'm not wrong, in February or March. And we enrolled 6,600 neonates in 5 district hospitals across India. And we found the incidence of culture positive sepsis to be 3%, roughly 3%. And if you look at, again, the resistance pattern, on the x-axis, again, you have the organisms, and then on the y-axis, we have the proportion resistant to antibiotic. If we look at Klebsiella, so let us look at the multi-drug resistant and carbapenem. So we are looking at the blue ones, the sky blue one, and the green bars. So if you look at a Klebsiella, 84% are multi-drug resistant, that about 55% are carbapenem resistant. Equally, again, slightly better, only 12% resistant to carbapenem, but still 84% resistant, multi-drug resistant. Enterobacter, around 40% carbapenem resistant, and about 90% multi-drug resistant. And Acinetobacter, 70% multi-drug resistant, and about 75% carbapenem resistant. So the issue of microbial resistance is not restricted to level 3 units or tertiary care units. It seems that they are spilling, this resistance pattern is spilling on even to district hospitals. And unfortunately, most district hospitals or most SNCs do not have a facility to do blood culture. And if you do not have the blood culture facility, and then it's how will you know the bugs are sensitive or resistant? How will you decide the antibiotic policy? That's a big issue out there. So there is high resistance to cephalosporins and moderate resistance to carbapenems, even in level 2 units or district hospitals. They are not very different, mind you. Now, if that's the case, how can we prevent antimicrobial resistance? If there's such a high incidence, how can we prevent? Broadly, you can think of three broad strategies. One, first prevent infections. And I think that's the most crucial step to prevent antimicrobial resistance. If you can prevent infections, then you have to you need to treat less, and then of course you will end up having less resistance. But I think that's a crux. Then the second is accurate diagnosis, and not treating everybody, but not missing a baby who is actually having sepsis. Accurate diagnosis, and then appropriate treatment. So we'll talk about in the stewardship program. We might talk about the first two: prevent infections. How can we prevent infections, and how can we how can we standardize the blood culture or the other diagnostic tests so that you can have a better, reliable, and rapid diagnosis. But the crux of this talk is treatment policy. Appropriate treatment, having an antibiotic policy and an antibiotic stewardship program, they are crucial to prevent and to reduce the antimicrobial resistance burden. And this we all know this is common sense. So when you have high antimicrobial resistance, then you end up using broad spectrum empirical antibiotics, and which will lead to more selection of resistant pathogens, and that will lead to high antimicrobial resistance. And that's the vicious cycle. There's no way you can escape from the vicious cycle unless you take steps to prevent infections, to have better diagnosis, and then you have a stewardship program. So that's why. The next part is what is actually, are there any antibiotic regimes which we can just select without thinking about or without even listening to this talk? What is the evidence for the antibiotic regimes in newborn sepsis? I looked at the Cochrane reviews. So this is the Cochrane review on antibiotic regimes for early onset sepsis. And this had only 5 RCTs, only 5 RCTs involving 865 participants. If we are about 80 of these, we might be treating more than this number in a month's time in India. Unfortunately, we don't publish and we don't evaluate these regimes. It's difficult to treat as well. It's difficult to do studies as well, but it's not impossible. So this Cochrane review had included only 5 RCTs involving 865 participants, and it concluded, and they compared the different regimes: penicillin plus gentamicin, peptaz with amikacin, ticagrelin with levodopa with piperacin, and so on and so forth. We'll not go into that because, as most Cochrane reviews, the conclusion is very easy. You can just close your eyes and you tell what is the conclusion of Cochrane review. So the current evidence is insufficient to support any antibiotic regimen. So there's no evidence to support one over the other. Now, what about late onset sepsis? There's again a Cochrane review. Again, only 5 RCTs, only 580 participants. Again, we might be treating more than this number in a month's time. The conclusion is the same. This current evidence is insufficient to support any antibiotic regime. So we do not have evidence-based treatment policy. We cannot have an evidence-based treatment policy. And this, to some extent, to a large extent, is understandable because even if you have a setting, for example, a high-income country setting, the typical pathogen is likely to be group B streptococci, whereas in India, group B streptococci is quite uncommon. So I would say it's almost rare. I would say it's conspicuous by its absence. So in that case, how can we extrapolate something, what is supposed to be the best antibiotic regime in high-income country to Indian setting, or from Indian setting to some other lower-income country, if the bugs are going to be different? We need something else. We need to look at something else. So what are the guidelines? This is the WHO aware antibiotic book. So I'm sure everybody knows this aware classification of antibiotics. So this basically access, watch, and reserve antibiotics. So these are the three categories. So this is the WHO aware antibiotic book. And of course, this covers everything from newborns to adults. And if you look at newborns, the first choice recommended by this WHO book is for sepsis, for newborn sepsis, is ampicillin or penicillin with gentamicin. So that's what they recommend. Ampicillin or penicillin with gentamicin. The second choice recommended by WHO is cefatoxime or ceftriaxone. And if you suspect staph aureus infections, then you give cloxacillin. So basically, you have cefatoxime with amikacin. The first choice is penicillin or ampicillin with gentamicin. The second choice is cefatoxime with amikacin. So that's what they recommend. That's WHO guidelines. Now, what about high-income countries? This is the nice guidelines by the United Kingdom. And this is neonatal infection, antibiotics for prevention and treatment. If you look at the recommendations for suspected early onset sepsis, the NICE guidelines recommend benzyl penicillin with gentamicin as first choice antibiotic. And for late onset sepsis, because they see more of Coagulus negative staphylococci, they usually start Fluclox plus gentamicin as first line for late onset sepsis. That's the recommendation by NICE guidelines. Now, what are the issues with this? If you use WHO or NICE guidelines, what are the issues? What are the issues? So if you look at this is an article which evaluated the coverage of three antibiotic regimes for the immunological infections in hospital settings across Asian countries. So the commonly used, the commonly recommended antibiotic regimes, the common three antibiotic regimes, how do they fare in, when in the hospital setting in Asian countries? And they on x-axis we have different countries. Now we'll focus on only on India. On the y-axis we have the isolates which are covered by the regime, and we have three regimes. The blue dot is aminopenicillin and gentamicin. So aminopenicillin, for example, amoxicillin and gentamicin. The amber color, the orange colored square is the third generation of cephalosporin, so ceftriaxone, and the blue color, sky blue color diamond is actually the carbapenem, europenem. So if you look at the isolates, the proportion of isolates covered by a particular regime, so cephalosporins, it covers only about 30% of the bugs which are isolated in practice. So it is about 4835 isolates. And if you look at ampicillin or amoxicillin plus genta, it is less than 50%. And only saving grace is meropenem or carbapenem, it's about 65%. So the first line, what is recommended by a high-income country guideline, like a NICE guideline, or even WHO, it's almost out because it covers only 30% of the common isolates in these settings, in most Indian settings. So we cannot resort to these antibiotics because they're unlikely to work. Therefore, we need an antibiotic policy which is tailored to your unit. So how do you formulate the policy? Now, antibiotic policy, I will cover under three headings, as I mentioned. First, we'll talk about empirical antibiotic therapy, how to decide an empirical antibiotic therapy for a unit. Second, optimization of antibiotic if you get a positive culture report. And then third, if you get a report which is shocking in the sense that it's multi-drug resistant or extremely drug resistant or even pan-drug resistant, then how are you going to treat? So these are the three broad the topics subheadings which I'm going to cover. So empirical, we talk about antibiogram, and optimization, we'll talk about targeted therapy and de-escalation, and multi-drug resistant, what the first choice and second choice. That's what the three subheadings I will talk about. Now, for empirical antibiotic therapy, we need some steps, and there are 6 steps. The first step is to have an antibiogram of a unit. The second step is to have a frequency profile of pathogens in that unit. The third step is to tabulate the sensitivity pattern for a single drug, that is monotherapy. Then tabulate the sensitivity pattern for the combination therapy. So you have AMP plus Genta, Peptas plus Amica, and so on and so forth. It's a combination therapy. The fifth step is to choose the first line antibiotic based on step 3 and step 4. And the sixth step is to have a second line or reserve antibiotics. So there are 6 steps. I will explain the subsequent slides, so don't worry about that. So first is to have an antibiogram. So what is antibiogram? So basically you collect data on the pathogens that are isolated in your unit and their antimicrobial sensitivity patterns. So you collect the data and then you make a chart out of it, you make a table out of it, and that's antibiogram. Depending upon the numbers you have, you need to have data of adequate number, I would say at least 30 to 50 organisms, so that you can have a proper, at least not proper, a good antibiotic quality, which can be refined with subsequent collection of data and subsequent years. So we need to collect the data for at least 6 to 12 months. You need to collect data. Then you enter the data separately for gram-positive and gram-negative organisms in any sheet. So any like a Microsoft Excel or Google Sheet or whichever sheet, electronic, not a database, electronic I would say electronic sheet, in which you can record the data, enter the data. So you have a sheet separately for gram-positive organisms and for gram-negative organisms. So this is how it will look like. So there's an Excel sheet in which we have these are gram-positive organisms, Enterococcus, methicillin-resistant spawns, and methicillin-resistant staph aureus. The site and the different. So we have for each column. Can I just take a call, which is urgent? Sorry. Hello. Yes, sir. Sir, Zoom. I mean, having a talk, sir. Just I'll call half an hour. Sorry. So this is how it will look like. So we have different drugs, amikacin, amoxicillin, ciprofloxacin, clindamycin, and so on. And then for each organism, so each row that is one isolate. And for each organism, we are going to say whether it is record whether it is sensitive or resistant or intermediate. So this is how we generate an Excel sheet for a gram-positive. And the same thing we do for gram-negative. That's the first step. Then the next step is to have a pathogen profile. So what is that? So basically, you create a frequency table of these isolated organisms separately for early onset sepsis and for late onset sepsis. And we, based on Dennis data and based on the subsequent data which we have generated, we strongly believe that the profile of organisms between early onset, late onset is not very different. But that's a general belief which we have. That's based on the data which we have. And over the years, you have learned this. But if your event is special and you actually have a different pathogen profile for your onset, then you need to have separate sheets for that as well. Otherwise, we just have one table for, irrespective of the onset, for one table for what is the common pathogen. Then the step 3 is to have antibiotic sensitivity pattern for monotherapy, the single drug. For each drug, you create a frequency table. So tabulate the antibiotic sensitivity pattern to each antibiotic. Again, for gram-positive organisms separately, gram-negative organisms separately. Because we know that, for example, vancomycin, we don't test for gram-negative organisms. There will be something which we won't test for gram-positive organisms. So we need to have this separately. For example, this is how it will look like. We have on the columns, we have different organisms, staph aureus, Enterococcus, Acinetobacter, Klebsiella, E. coli, and different antibiotics. And then for each antibiotic, what proportion is sensitive or resistant. So that's how you create this table. This is sensitive to single drug, single antibiotic, that's monotherapy. For example, here, staph aureus, about 60%, it is sensitive to suboxetine. It is actually the equivalent of methicillin. So that means it's methicillin sensitive, 60% of methicillin sensitive. And it's only 18% sensitive to amoxicillin and about 30% to ciprofloxacin. So that's how you interpret this. Now, what about, if you look at the gram-negative organisms, Acinetobacter, Klebsiella, E. coli, you can see that about 60% sensitive to Staphylococcus bacterium, about 75% of E. coli sensitive to Peptides, and so on and so forth. Now, the next step is to have a sensitivity pattern for combination therapy. It means you have antibiotic sensitivity patterns for combinations. So if you have this plus that, in that case, if the bug is sensitive to at least one of the combination. So if you make it two, then it will make it specific. But depending upon, so you make it okay, at least one should be sensitive to. So for gram positive and gram negative organisms separately, and then you make it a combined table. Then once you've made this table for combination therapy, then the next step is the choosing the first line antibiotic. So then based on this, once you've generated a sensitivity pattern for different combinations, then you choose the combination which should cover at least a combination therapy or even a monotherapy, which should cover at least 60 to 70% of the most common organisms. I would say 3 to 5 most common organisms that roughly, you can say two-thirds, it should cover two-thirds of the two-thirds of the organisms. The commonest 2/3 of the organisms which you have in your pool, of that, at least two-thirds should be covered by this antibiotic. The antibiotic which you choose, that's the first line antibiotic. And there are some rules. In general, avoid broad spectrum antibiotics as a first line antibiotic, for example, third generation cephalosporins and carbapenems. You don't use that as a first line antibiotic. What about the second line antibiotic? Now, you determine which antibiotic combination would cover at 80 to 90%. So 60%, we said 60 to 65% for first line. And we are talking about an additional 25 to 30% that would be covered by the second line. So that's the second line antibiotics. So you determine which antibiotic would cover 80 to 90% of the common organism. Then these are not hard and fast rules. These are just like common things, just 60 to 70% for first line and 80 to 90%. But you can titrate, you can tweak it. But these are just broad principles. And if you have high baseline medicine-resistant Staph aureus or medicine-resistant coagulation like staphylococcal infection in your unit, then you might add vancomycin as a second-line antibiotic instead of adding something to cover, changing to a better gram-negative coverage. You can actually think of adding vancomycin as a second. So it depends upon the unit. The second line versus reserve antibiotics. Now, second line, and then you have a third line that is the reserve antibiotics. That it depends upon usually based on the cost, its safety profile. For example, you don't use phosphomycin, for example, or chloramphenicol as the second line. So you have, based on the safety profile, you have something at the end, so that if nothing works, then you can have that as a reserve antibiotic. Then broad spectrum versus narrow spectrum antibiotic. So depending upon these principles, then you can choose a second line antibiotic. For example, we will go back to the example it showed you. So here, this is a combination therapy. So for Staph aureus, Cipro plus gentamicin, 80% of the bugs sensitive. And Enterococcus, 80%, 100% are sensitive. But Cipro's genta covered only 10% of Acinetobacter, but 70% of Klebsiella and 100% of E. coli. So here, roughly, it will cover about 60 to 70% of the common isolates, except that if it's Acinetobacter, that particular baby actually turned to have Acinetobacter, then that bit might be at risk. But that's the risk we have to take so that you can avoid. So for a particular baby, it might be thing, but for overall unit and for the future in your unit, it's a trade-off you're going to take. So you might think Ciprogenta as a first-line antibiotic, and then you will then you look at which other combination will make it from 60% to 80% or 90%, and then that makes it the second line. But the problem is so much work, it's tedious, and with the current this thing of chat GPTs and automations. So we don't want to even Google anything. We just put in chat GPT and get answers. Then that's how we have become so lazy. So how can we automate it? So what we thought was, if we can make an automated technique, we try to develop a AMR cure guide, a smart assistant for deciding the antibiotic policy of a unit. So this is the work in progress. We have developed this over a few weeks, and we have tried to test it. And if we test it and then it works well for some units, and then we plan to publish it and then make it open access so that anybody can use it. So this basically this is developed with the help of a IIIT Delhi and with the AIIMS team at the Delhi. We are developing this. It's a web-based tool. So it will look like this. So you have a username and password. And once you log in, then you can enter the data. So we have a drop-down menu for all the organisms. So you can select the organism. So here we have selected Acinetobacter baumannii. And then for each, then you have all the drugs listed. So amoxi, comox, classification. So then we just select yes, intermediate or not tested. So you select one of these. So you do for each bug and for any unit, and then for each bug, for each drug, you enter this data. And what we're trying to do is automatically once you enter the data, then a dashboard comes in which you say the first line combination, it gives first line combination and the second line combination, it just gives a suggestion. Then you can choose based on that, okay, amoxicillin could be the first line and the second line could be piptazamicrob. So this is for we just a test run we did, and then this was a suggestion. We will test it with more data from more units, and we will publish it, and then we are trying to publish it, and then we'll try to make it open access so that people can use it instead of using these fixed steps. Now, the next question is, if I do not have local data, what I will do? That if you have a local antibiogram, that's the first strategy, what I said, the 6 steps is going to work. So if you do not have data, then what I'm going to do? So there are only 3 steps. Step 1 is collect data. Step 2 is collect data. And step 3 is collect data. So there is no escape from collecting data. So even if you are if you are just joined a phase, or you just opened a NICU, or you've taken over a NICU, for example, and no data still now, but make sure that the next 6 months you have data. And without that, you cannot have an empirical antibiotic policy. And if you don't have in the first 6 months, if you don't have, no way you can get data within the first 6 months or 1 year, because you just joined or it's a new NICU. What you can do is you can use regional data. You can ask the neighboring units or the state, for example, or the region, district, and if that is also not feasible or possible, then you can use the national data. And if that is also not available, which I don't think it's a lazy excuse, but in that case, a really empirical choice you can choose for the first 6 months or 1 year till you get the data. Now, this is the national level data. This is we published in a review, systematic review in BNG 2019. And this table provides the antimicrobial resistance pattern in South Asia, but predominantly the organisms are from India. So we can sort of equate to antimicrobial resistance patterns in India. So if you look at Acinetobacter, for example, the numbers are quite significant, means so substantial. So 633. So Acinetobacter overall, you have 1,350 odd Acinetobacter isolates. So 86% resistant to ampicillin, 68% resistant to gentamicin, 63% resistant to amikacin, 80% resistant to peptidecins, and 70% resistant to ciprofloxacin. And that is really alarming. And even European is 65% resistant. So that's for Acinetobacter. So if you don't have any data, then look at the national data and then see whether we can make. But that ultimately might end up with having a very reserve antibiotic in first line. So I would strongly recommend using regional data, ask your neighbors, your neighboring units, and then make a policy accordingly, and then try to collect data in the next 6 months or 1 year, and then make an antibiotic policy. So this is the empirical regime we suggest in units which do not have data. So this is based on, of course, based on WHO and the high-income country guidelines. But these are the situations in which the risk is likely to be too low. For example, level 2 unit that caters to only stable units. There's no indiscriminate use of antibiotics. In that case, ampicillin or cloxacillin plus an aminoglycosides, gentamicin might be helpful. If it's meningitis, then you go for cefotaxime plus an aminoglycoside. But the second situation is likely to be the most prevalent in most units. Most strains are likely to be resistant. So you have 2 options: Cipro Omega as the first line, and Pictus Omega plus or minus antibiotic as the second pass. So that's is again a broad rule of thumb. But I am again stressing that point. You need to have your own local antibiogram. Now, that's the empirical antibiotic policy. Now, how to titrate once you get a positive culture? Now, that's 2 things. One is de-escalation of antibiotics and titrating antibiotics. What is de-escalation? So de-escalation is replacing the broad spectrum antibiotic with a narrow spectrum antibiotic or an antibiotic that has a lower ecological impact. We'll not go into that, but broadly, a broad spectrum antibiotic is replaced by a narrow spectrum antibiotic. Or if you're using a combination therapy, and of that combination therapy, only one is more than enough, or the other is resistant, in that case, you should stop the one component of the combination therapy so that you can prevent resistance to that component. And de-escalation, there are many, people have ranked the antibiotics, and there are many ranking systems available. And these are the two commonest ranking systems that are commonly used. One is these et al. These are quite old ranks, but we can still use it. So this is ranked from, these rank from 1 to 6 in terms of increasing or in terms of keeping it in reserve. So amoxicillin is to be used, and then amoxiclav, and then third use of sporins, and then peptides, and etapinum, and then ebipinum. But slightly different in the spectrum score by Kelly et al. There it is the amoxi, and then third use of sporin, and then amoxiclav, and then etapinum, and then so on and so forth. But broadly, you can say that amoxiclav, and then cephalosporin, and then beta-lactam combination, then the carbapenem, roughly. So if your carbapenem, if you have started a carbapenem therapy, but the bug is actually sensitive to peptides, right? Then you de-split the peptide. Or if it is even sensitive to amoxicillin, then you de-split amoxicillin. So that's basically you are going from 6 to 1 if possible, and that is de-escalation. That's de-escalation. Now the last part is, if you have multi-drug resistant or difficult to treat pathogens, difficult to treat Pseudomonas, for example, or extremely drug resistant pathogen, then how are you going to treat? Now, before that, we should know how to define multi-drug resistant, how to define extremely drug resistant, and how to define pan-drug resistant. And there are many definitions which are available, but this is one of the commonly used definitions. And I believe this is one of the easiest definitions also to follow. This is a major occurs in 2011. The multi-drug resistance to one agent in 3 or more antimicrobial categories. Resistance to one agent in 3 categories or more. Extreme drug resistant is resistant to one agent in all but 2 or less. Resistant to most categories, but it's sensitive only to 2 categories. Or like pan-drug resistant is resistant to all agents in all categories. So now we should know what are the categories. So these are the categories. One is aminoglycosides, anti-pseudomonas carbapenems, then anti-pseudomonal cephalosporins, anti-pseudomonal fluoroquinolones, anti-pseudomonal penicillins, plus beta-lactam plus beta-lactam inhibitors, BLBLI, then monobactams, then phosphonic acids, which is phosphomycin, polymyxin. So we have 8 categories. So if this bug is resistant to 3 categories, so these are multi-drug resistant. Acid number 2 is mostly resistant, but it sensitive only to 2. Therefore, this is extremely drug resistant. And acid number 1 is resistant to everything, so this is a pan-drug resistant. Right now, we'll talk about we'll leave the pan-drug, we'll talk about extremely drug resistant and multi-drug resistant, how are we going to treat. Now, first, we'll talk about multi-drug resistant enterobacterials. That is basically E. coli, Klebsiella, all the enterobacteria and so on. So the enterobacterials. If the bacterials, for example, Klebsiella, is resistant to third generation cephalosporins. Basically, the beta-lactam is producing. Now, when will you suspect ESBL? If you have resistant to ceftriaxone, and if you have MIC, the minimum immunity concentration is more than or equal to 2 micrograms per ml. In that case, you suspect extended spectrum beta-lactam is producing organism. And for this, the first line is meropenem. So if you have strong suspicion that this could be ESBL, extended spectrum beta-lactam is producing enterobacterial organism. In that case, meropenem will be the first line. And if the Klebsiella or E. coli or Protease or Enterobacter, they are resistant to carbapenem. Then if you have a panel, molecular testing, which is available, that will give the antimicrobial resistance genes, or there are phenotyping to detect the genes, to detect whether it's the mechanism of resistance. We're not talking about resistance, we're talking about the mechanism of resistance. One is the gene. If you can identify the gene, so if it's a carbapenem is producing bacteria, that means if it has either KPC gene or MBL gene or OXID gene, in that case, you have ceftazidime-avibactam or a combination of ceftazidime-avibactam plus aztreonam. Broadly, if you send what we call any multiplex PCR, which usually blood tests, you will usually have microbial resistance genes as well. They will not do only organisms. They will also detect the genes. So if it's a KPC, then you have one ceftazidime-avibactam, or OXO, then ceftazidime-avibactam. But if it's the MBL, that is metallo-beta-lactamase, of which the most common one is New Delhi metal-endium, the New Delhi metal-beta-lactamase. So that, then in that case, you have to use a combination of ceftazidime avibactam plus aztreonam. Cefiderocol, as far as I know, it's not available in India. So, but these are the recommendations of IDSA. So this is what you use. Now, what about Pseudomonas? Multidiagnostic or extremely diagnostic Pseudomonas. If it's carbapenem resistant, but it is sensitive to beta-lactam, it's unlikely, but it can happen. So it's resistant to carbapenem, but it is sensitive to beta-lactam antibiotics like Piptaz. In that case, the first line is Piptaz, but is higher dose. So high dose extended infusion of Piptaz. But if the baby is sick, in that case, you go for a newer beta-lactamase inhibitor, that is ceftazidime-avibactam or ceftolozumab tazobactam. So ceftolozumab tazobactam. So you use either of these. Now, if it is difficult to treat Pseudomonas, then again, if you have genes, whether it is NDM producing or non-NDM producing, depending upon that, you will choose the antibiotic. So what about Acinetobacter? For Acinetobacter, if it is carbapenem resistant, that is CAB, carbapenem resistant Acinetobacter baumannii, the first line antibiotic sulbactam, durlobactam, plus meropenem. That is the first choice. And if you don't have, then sulbactam, durlobactam, which is not easily available, then you have ampicillin sulbactam at a higher dose with the polymyxin B. IDSA guidelines as well as European Society guidelines, they do not recommend cholesterol for bloodstream infections. They recommend cholesterol only for cystitis. So they recommend polymyxin B as a, if at all, and again, they in general, they do not recommend polymyxins. They usually go for other, as you can see, ceftazidime-avibactam plus aztreonam or ceftazidime-avibactam for extreme resistant. And for crab, they use, they ask for sulbactam, durlobactam or meropenem. Or the second line is ampicillin sulbactam plus polymyxin. So this, you don't have to remember, just go to the IDSA guidelines, and then if you're going to deal with these organisms, then you need to have this these drugs in your unit, as well as the knowledge of how to use them in your unit. So that's the first part. So I will end with a quote. I do not know how many of you have heard about this Spitzer's laws of neonatology. It's a very interesting laws of neonatology given by Spitzer. And of this, one of the laws I would like to highlight here. So Spitzer's laws says that if you can't figure out what is going on with the baby, call the surgeons. They won't figure it out either. So they will also not know what's happening, but they will sure as hell do something about it. So that's the Spitzer's law of neonatology. So if you make it a new law of neonatology, what we have been doing now is if you can't figure out what is going on with the baby, start or change antibiotics. That's what we have been doing for the last few years. And I think that's wrong because antibiotics will not figure out what is going on with the baby, but they will do something causing resistance. So don't do that. Okay. I think that's the first part of my talk. I'll stop here. And if you're not tired enough to take the second part, then I will take the second part. Otherwise, we can close it here.
Uh, I think we can have the second part, sir. Not an issue. The second talk, everyone will agree, sir. Definitely, we can have the second part.
Okay, fine. Well, just a minute. Is status visible now?
The old one only is visible still, sir.
Oh, okay. Okay. Just a minute. Hello?
Yes, sir.
Okay. So the second part of my talk is on antimicrobial stewardship program. And this, I will not talk about that. We've already talked. But more important is, which I didn't talk about. So the 10 million deaths of that, about 5 million deaths are going to be in Asia, of which we know that India will be the major contributor. So if the situation is going to happen now, is we are not going to do anything. And by 2050, 10 million deaths every year are going to be actually due to because of AMR, and of which a significant contributor will be India actually. So we need to do something about it. So what I'll do is, what is the antibacterial stewardship program? So I'll define, and then I'll provide the components of stewardship program. How to set up an antibacterial stewardship program. So I'll talk about the principles and examples. Now, as I mentioned, to prevent antimicrobial resistance, you need to do some steps. So these are the 12 steps recommended by CDC, the 12 steps for prevention of antimicrobial resistance. I'll start from the base. So first, this is of course antimicrobial resistance across all age groups. So some of them might not be relevant to newborns. So for example, the first is vaccinate. So newborns, right now, newborn vaccination is unlikely to prevent the newborn sepsis, but of course, people are working on Klebsiella and other organisms, or better vaccination, so to prevent sepsis in the babies. But till that time, this might not be as applicable. But the second is very important: get catheters out. Always, every day, think about whether this catheter needs to be there in the baby or not. Get catheters out as early as possible, as soon as possible. Not even a single or extra hour should be done. Then use proper diagnostic methods. Target the pathogen. Don't just here treat everything. It's not like a fishing net. You want to have everything. Target the particular fish which you want to have. Access the experts if you have doubts. Practice antimicrobial control. Have the sense, you should have the courage to stop antibiotics and not to start antibiotics in a particular baby, in which you can monitor the baby instead. Use local data to create an antibiogram and then an antibiotic policy. Never treat colonization. Colonization is not equal to infection. You should know when to say no to antibiotics. I think that's a very important aspect of being a clinician and a neonatologist. You should know when to say no. Stop treatment at the earliest opportunity. Infection control and hand hygiene. So broadly, this could be grouped under hand hygiene, infection control, and catheter. So these are preventing infections and target the pathogen, proper diagnostic methods. These are diagnostic strategies. And stop treatment, when to say no, not treating colonization. These are treatment. So broadly, the 12 steps can be grouped under what I said is the three categories: prevent infections, accurate diagnosis, and appropriate treatment. Prevent infections, you can start with simple bundles. There are bundles we know bundles for VAB, we know bundles for CLABSI, but at least we have simple bundles for even prevention of infection, induction infections in the unit. And of course, it goes without saying the hand hygiene is a crucial step. And without that, then you cannot prevent infections. So make sure that you have to religiously follow hand hygiene. There's no escape from that. Accurate diagnosis, you have to standardize cultures, and biomarkers you should use wisely. I will talk about that in the subsequent slides. And appropriate treatment is antibacterial stewardship, and that's what we are talking about. Now, how to make an antibacterial stewardship program? What is stewardship program? It's a coordinated program that promotes appropriate use of antimicrobials, improves patient outcomes, reduces antimicrobial resistance, and it decreases spread of multi-drug resistant pathogens. So it's a coordinated program with multiple objectives. One, to promote appropriate use of antibiotics, to reduce antimicrobial resistance, and to reduce the spread of multi-drug resistant pathogens. These are the broad, the team members you need if you can, but in India it's not so easy to get a infectious disease trained pediatrician. But now there are some DM programs coming up on infectious disease, so we might have in a few years' time. But there are some hospitals they do have infectious disease, but I believe that's not mandatory. A neonatologist with good knowledge of sepsis and antibiotic therapy is more than enough. We need a nurse practitioner or a nurse. Pharmacist, again, in most units, we do not have a pharmacist, but if you do, even if you're in a college setting, for example, you can always involve the pharmacology department or some of the faculty from the pharmacology department. So to provide some feedback and then to titrate it. Of course, you need a microbiologist. There's no escape from that. And there's some managerial, like hospital epidemiology administrator. And we need a person who has access to basically information technology person who can enter the data, who can analyze the data, interpret the data, and then give the feedback to the other team members. So that's the team for antibiotic stewardship program. And there's a toolkit available for antibiotic stewardship program for low and middle income countries, just published by WHO in 2019. This is free downloadable. WHO, if you see WHO antibiotic stewardship program toolkit, and it's very easy to read. And these are the steps they have. These are the components of stewardship program they have mentioned. So you need a commitment from the leadership. You need to fix accountability and responsibility of different team members. Then you decide which action you are going to do, which component or which actions you are going to do. Then you need a reporting and feedback mechanism to see whether it is working or not. Then you monitor and surveillance what is happening. Then you educate and train. So then it's a cycle. And then you again do further titrate the actions and the components of antibiotic stewardship. Then you monitor, then you give report, and then further actions, defining the actions. So these are the components of antibiotic stewardship program. Broadly, stewardship actions or the components are two levels. One is clinical pathways or education. So educating the treating neonatology, the faculty, the residents. Basically, you need to sensitize them to stewardship program and then to use antibiotics not in an indiscriminate way. The second level of intervention, which is what I'm going to talk about, is on this prospective audit with intervention and feedback. That means if somebody is starting antibiotics, then the next day or that week, there's an audit of that. Okay, why was this baby started on antibiotics? Okay, which antibiotic you chose? Why did you choose? So there is a prospective audit. And with intervention feedback, I provided to the treating team so that there is a continuous learning process, and then slowly the antibiotic policy becomes much more manageable. But here we'll talk about in the subsequent slides, I suppose. Then the second is formulary restriction and pre-authorization. So formulary restriction is possible in many high-income countries, and even in some settings in which it comes from a pharmacy. So there, the pharmacy itself says, if you say meropenem, the pharmacist will say, no, meropenem is not allowed unless you get these meet these criteria. So that is a formulary restriction. But short of that, we do not have, because of pharmacist-controlled drug dispensing mechanism in India. So we can do what we call the pre-authorization. I'll explain in the subsequent slide. The prospective audit and feedback is basically an external review of antibiotic therapy. Every baby who is started on antibiotic therapy, so you fill a sheet and then you say that what are the indications or what antibiotic started, whether you send the cultures or not, and then that is audited. The sheet is audited and along with the case file by the ASP team. If the numbers are small, they can audit all the babies. Otherwise, you can audit you can randomly pick up a few babies and then you audit. And how will you audit? And then you have unit-specific guidelines. So these are the treatments. So this is the first line, and then the ASP team will check whether you have started the first line. If you have changed to second line, whether that is based on the principles which you have already mentioned or not. And this audit obviously will be done after you initiate therapy. So this is not before initiating therapy. So this is after initiation of therapy. This is the most effective intervention of all the strategies which we have. This is the most effective strategy. But the problem is, most clinicians, most neonatologists, even whether it's a resident or a faculty, we do not, we are not comfortable when somebody questions our decision. And particularly somebody who has not seen the baby, we will say that, oh, you didn't see the baby at 1 a.m. The baby was sick and that's why I started on meropenem. So that will always be a problem. And our ego gets hurt, and we cannot take somebody coming and criticizing our antibiotic policy. So this is most effective intervention, but it is possibly unlikely to be effective or feasible to implement in India. So what we can do is, if you for this audit mechanism to happen, we need guidelines or clear recommendations, and that guidelines should be based on local antibiogram, and that is used by the ASP team. Now, these guidelines, for example, at AIIMS, we have this antibiotic policy. So that's available in app for an Android phone or whether it's Apple phone. And these are different. So you can select, you can click, and then you could choose, okay, which first line antibiotic for antibiotic naive patients. And so this is NICU, early onset sepsis. So even if a new resident joins, then they do not know, and they are shy to ask the seniors or colleagues, then you can just select this and then okay, which antibiotic you can give. So that's the antibiotic guidelines. So based on these guidelines, the antibiotic stewardship program team will audit. So for that audit, the treating team will fill this antibiotic sheet, and then this will be audited by the antibiotic sheet program. But as I mentioned, this is unlikely to work in most units because of various issues. So the second strategy, which I'm going to talk about, is pre-authorization. So this is likely to work in many units in India. So what is pre-authorization? Here, the clinician should get prior approval from the ASP team before starting antibiotics. So here, in the formula, the audit mechanism, that is, audit is done after you start antibiotics. Here, whether it is formulary restriction, it is not possible in most settings in India, or pre-authorization, you get prior approval from the ASP team before starting antibiotics. And this is a pre-specified list with multiple level authorization. I will explain the subsequent slide. You'll understand better. And of course, this is before initiation of therapy. And the ASP team will just monitor whether you're adhering to this, because once they have given the approval, whether you're adhering to this or not. So this is a formulary authorization policy for our Department of Pediatrics. So here, these are the different antibiotics. So here we have different hierarchical authorization. For example, colistin or polymyxin. So here, this will be done by the head of the department. As a faculty, I cannot start colistin. For reserve antibiotics like tigecycline, aztreonam, or ertapenem, then the unit chief has to permit. Again, I cannot. The unit chief has to give permission. For as a faculty, I can the 5th to 14th. So Vancouver, Tico, Lido, Miro, VVPNM. So here, as a faculty, I can decide. As a senior, at the senior resident level, you can do you can start only ceftriaxone, cefotaxime, ceftazidime, amoxiclav, and so on. As a senior resident, you cannot start cefoperazole, bactam, or peptides. You need permission from the consultant. And as a faculty, you need a permission from the unit chief for example, aztreonam or ceftazidime, bactam. And for polymyxes, you need actually permission from the unit. So this, instead of ASP, if you have ASP team, then instead of this, you can actually replace with the ASP team. But otherwise, if within the department itself, you can have such level of authorization that will make sure that, okay, you don't indiscriminately use polymyxins, for example, and you don't indiscriminately use ertapenem or aztreonam, for example. There are some broad principles of stewardship. So this one is pre-authorization. The second is there are some basic principles. So these are the get smart the get smart principles. For example, these are some which are common sense principles. For example, avoid therapy with overlapping effect. That is, avoid simultaneous use of metronidazole and meropenem to treat MSC. So if you give meropenem, or even a third means beta-lactam inhibitor, most beta-lactam antibiotics, they cover anaerobes. There's no need for additional metronidazole. But unfortunately, most pediatrics just do not. You have to make them understand. You have to involve your team, involve the pharmacologist, microbiologist, and then say to the pediatrics and say that there's no point. Okay, I will give some concession, frank preparation. Okay, we might add metronidazole, but no. If otherwise, there's no need for meropenem plus metronidazole. There's no need for meropenem plus amikacin. You should not have something which is a combination, just superfluous, and it's not going to help at all. Use local antibiogram, of course, you need, and right dose, right interval, review culture reports, and then de-escalate the therapy. Monitor for toxicity and then adjust the antibiotic therapy accordingly, and stop therapy if the culture reports. So stop believing in your culture reports. And these are some targets. So by which strategies by which you can actually have antibiotic stewardship program in your unit. So your early on sepsis, these are again from high income countries. They use a sepsis calculator to identify babies who need antibiotic initiation. For late on sepsis, prospective audit and feedback or pre-evaluation and so on. And for MEC particularly, avoid antibiotic use with redundant anaerobic activity. Perioperative prophylaxis for clean procedures you don't need at all. And if you're fit all for surgical conditions, for example, there's a possibility that there may be consumption from the gut, and then it can limit the preoperative exposure as with 1 day, 2 days, or 3 days, not beyond that. And then diagnostic stewardship. Okay. So this is the early onset sepsis calculator. This is a case permanent calculator, which is used in high-income countries, and this has a different predictors. So, what is the incidence of early onset sepsis in that unit? The gestational age, highest metal antibottom temperature, highest means intrapartum fever, basically, the duration of rupture of membranes, and the most important is they ask for group B streptococcus status of the mother, and whether intrapartum antibiotic prophylaxis has been given to the mother to cover group B streptococci. And as I said, in Indian settings, most Indian settings, and almost I would say almost all Indian settings, the group B streptococci is quite rare. So this calculator is just not, we cannot extrapolate, we cannot use it in our in Indian units. So, but this calculator has been found to be reduce antibiotic therapy in about 200,000 newborns every year in the States of America itself. And then many high income countries have reproduced these results. But the problem, as I said, is the applicability in Indian settings is I would say, is nil. So we try to develop a machine learning based model, something similar to what the US calculator does. So we try based on the Dennis data, and there's a machine learning based model which has about 30 variables. So it's not only 4 variables like US calculator, but these 30 variables are unlikely to take more than 2 minutes to enter. And we have developed a web page in which this can be entered. And once you enter the data, then it will give a prediction. What is the likelihood of sepsis invariability? And based on that likelihood, then you can do, okay, it's more than 30%. Okay, I will scan the baby, start the baby on antibiotics. More than 70%, I will start the baby on antibiotics. 10%, 20%, 30%, I might wait. So that we are trying to develop, and we are trying to validate in district hospitals this calculator. And we once we validate it, we will again keep it open for public use. So there's such idea for those who are interested. Is if you're interested, then we can, once we get the funding, we will be happy to have some people on board to validate this tool. Now, diagnostic stewardship, how can we make a better diagnosis and therefore reduce the need of antibiotic? So this is Dennis data in which we found that even with the best, means one full dedicated research nurses, dedicated research staff in the microbiology lab, I imported culture media and continuous monitoring of by nodal center team. Even with that, the culture positives were only about 40%. In the normal setting, culture positives is only about 10 to 20% of all babies who are suspected of sepsis. So we are predominantly going to deal with the culture negative sepsis. So my practice tips to reduce false negative culture. So that means baby is really having a sepsis which is caused by an organism, but you got a culture which is negative. So how can we reduce this false negative blood culture reports? So these are the sub tips. One is you need adequate sample. So you don't waste blood in sending multiple CRPs, procalcitonin, and all those monospecific biomarkers. Stop doing that. If you get one number, send that one number for blood culture. Always sample before starting antibiotics, whether it is 1 a.m., whether it is 12 p.m., whether it is 5 p.m. when you have tea, coffee time, nothing doing. You before the first dose of antibiotics, you have to do sampling. Invest in good quality media. Don't invest in IV mirapion, vancomycin, and ceftazidime, avibactam, and astrium. And instead, make sure that talk to the MS, talk to the microbiology, make a team, and then ask them, okay, provide good quality media to them. Make sure that you get, if you can, get automated blood culture bottles. And depending on, you read, if you're using automated blood culture bottles, some they will say some to keep in the room temperature, and some will say that, okay, can you keep it at 37 degrees, depending upon the which culture bottle you're going to use, then you have to incubate it. So this is this is about 30%. You can set the temperature, and particularly in conditions in which the temperature is likely to be 20 degrees or less than that, in that case, use this incubator so that you keep it at least 25 degrees or above, or depending upon the bottle which you use, you can keep it even at body temperature, that is 37 degrees. That is to reduce false negative. Now, on the other hand, you can have contaminated. So sometimes when 3 organisms grow on, 5 organisms grow on, or skin common cells grow on. That's a very common report which you see. So how to reduce contamination? Because contamination, you will be confused whether to treat or not. So that's the other set of tips. Make sure that you clean the skin for at least 30 seconds before you blood culture, and use either chlorhexidine if your unit accepts that policy, or use 3-step method. So use first alcohol, then powder iodine, then alcohol, 3-step procedure. Have a research nurse if you have a research project running, or a phlebotomist or nurse doing sampling. I'm not saying that residents should not do sampling, but If you have a unit which has a moving population, for example, MD residents, because they are going to come every 2 months, every 3 months, or 4 months, it's better to shift the culture sampling at least to the nurse, because the nurses are going to stay there for a longer period of time. But if you have fellows like a DM or DNB fellows, so who are there for going to be there for 3 years, in that case, then they can do the sampling per culture. So make sure that somebody who is going to be there for a prolonged period of time, they do the sampling. Avoid open system. Don't collect from the hub or break the needle and then take it. That is you don't do for culture. And then that will lead to contamination. And if you're using traditional culture bottles, then clean the cap with the same alcohol or iodine and then incubate it. Go to the microbiology lab, talk to the microbiologist, and then make sure that how can we reduce contamination in the lab itself. Okay? Now, what about other tests? So if the culture is going to be negative in 20 to 40%, then what about biomarkers? So tests for diagnosis or other tests. So you can have a hematological, like white blood cell count, absolute neutrophil count, immature to total neutrophil ratio, acute phase reactants, CRP, apocalcitonin, cytokines, systems of first markers like IL-6 and IL-8, and molecular diagnostics like PCR, multiplex PCR, and so on and so forth. And you can have a combination of everything. Now, how do they perform? So in simple words, they're like Indian cricket team. They're good, but they are not the best. So don't rely too much on them. So they are not the world-beating West Indian teams of 1980s or 2000 Australians. So they are not. They are okay. And if you look at CRP, for example, it has a very poor positive predictive value. It's only about 30%. So that means 2 out of 3 with a positive CRP will not have sepsis. 2 out of 3 will not have sepsis even with a positive CRP. So think about it. So use a CRP if it's a negative, so you can stop antibiotics. But if it's positive, don't start antibiotics. You still think whether you can start or not. So basically, use the principle of high negative predictive value. So these tests are to be used to rule out sepsis, but do not use them to rule in to start antibiotics. Don't share or put the blame on CRP to start antibiotics. Have the courage and have the accountability to start antibiotics and then say that, okay, I start antibiotics because of this clinical guidance. It's not because PCT was positive or CRP was positive. Don't do that. The key messages, so this is the last slide. So antibiotic stewardship program is essential in every NICO. It's a collaborative effort. It needs team. Audit and feedback, prospective audit and feedback is the best strategy, but unfortunately, unlikely to work. Pre-authorization is more feasible and definitely implementable. Make sure that you have a local antibiotic policy and follow that. Do cultures. Don't waste time on and money on other diagnostic tests till they are proven to be superior or they are equivalent or non-inferior to the traditional cultures. Thank you. I'll be happy to take questions.
Thank you so much, sir, for the extensive session. We have questions in the chat box, sir. I'll just read it. First question is, we happen to have a case scenario like a neonate, suppose on gentamicin since last 3 days, deteriorated clinically, and antibiotics were upgraded to meropenem after obtaining the blood culture. Baby improved clinically. Later, this blood culture grows an organism which is sensitive to gentamicin with good MIC. How to de-escalate in these situations, in vivo versus in vitro sensitivity?
Yeah, in vivo versus in vitro sensitivity is always an issue. If the go by the clinical scenario, if it is only that, usually we don't give a monotherapy with aminoglycosides. You would have given something else. This seems to be more of a hypothetical scenario. But if that is the case, if there is a deterioration and therefore is ordered antibiotic, and then it comes out to be sensitive later, and you have to go by the clinical this thing on there, and there's no other explanation for that deterioration. I think that's very important. The problem is we say that deterioration be equated with sepsis. If there could be some other reason for that deterioration, something else, suddenly the ductus opened up, for example. Suddenly there was abdominal distension, and it was just a case of MEC not going into the bloodstream infection. So there could be some other reason, or it could be IVH, for example. So many things can happen. So it could be just apnea, which will be that manifested later. If there is no other cause for deterioration, and you believe that deterioration is more likely because of that, the bug was not sensitive to that antibiotic which was being used, and therefore they are upgraded, and then the big showed improvement. Then you continue with what you started recently.
Any test to differentiate in vivo versus in vitro sensitivity?
As far as I know, no.
Any role of MIC in deciding the antibiotic use? If sensitivity to more than one antibiotics, can MIC guide which one will be clinically more effective based on MIC?
Yeah, MIC, that is like what we have like a therapeutic index. We have a MIC therapeutic index as well. So there is we have uh, I would share this thing. So maybe I will share that chapter which we have written by Dr. Sindhu. So we have provided how to use MIC to decide the antibiotic policy. You have to choose between the antibiotics which you can choose. So I will share the chapter with you, and then you can share with the other group.
Use of monotherapy in first line.
Uh, Use of monotherapy. Yeah, you can. The combination therapy. So, for example, peptides, use of monotherapy. Definitely, you can. Um, Synergistic action with aminoglycosides is generally believed to be true, but not necessary in every case. And second, it may not be required as well. So monotherapy is fine. If it covers 50% of organisms, so you're perfectly fine to have peptides as a first line, only monotherapy. But monotherapy with only aminoglycosides, I will be a little skeptical.
Are we justified in using colistin along with tetracycline combination for oxycyclinase alone, producing crab and E. coli?
Cholesterol plus tetracycline combination. Tetracycline combination is basically talking about, I am assuming that it will be, which tetracycline?
They just written,
Minocycline or the other one?
haven't mentioned, sir. Generalized the mention as tetracycline.
Yeah. So I would say go by just go by the IDC guidelines. For crab, I think you need to have sulbactam as first line.
What was the first line antibiotic before 10 years in AIIMS and now?
AIIMS antibiotic policy is not relevant to others. So, as I said, unit antibiotic policy is important. AIIMS antibiotic policy is not relevant only for AIIMS. It's not relevant for any other units. So, this question is not valid for others. And the answer is not important for others.
Update on
Minocycline. Update on, sorry?
duration of antibiotic recommend.
No, I have not touched upon that as well because actually just now there is a study published in ADC. Those who know, it's a multicenter study done by Dr. Saurath's group. 7 days versus 14 days in cancer reception. So it's a ongoing topic of discussion. So for now, what we follow is 10 to 14 days for culture, positive sepsis, and meningitis we go for 21 days.
How to test combination sensitivity in an organism?
That's there are. I'm not sure how many of you have read there's an ICMR book on multi-drug resistant gram-negative organisms, and that's a very good book. So the first few pages are actually on how to test the antibiotic sensitivity part. So there they would provide ceftazidime avibactam plus aztreonam, only ceftazidime avibactam. So they provide clear guidelines how to test for a combination. But otherwise, normally we don't. But there, if you high-level aminoglycoside, I'm not sure how many of you look at when you in the sensitivity pattern. So last row will be usually high-level aminoglycoside. That actually indicates synergistic action of aminoglycoside with the beta-lactam antibiotic. So you have to read. There's no escape. So you have to read.
Use of antifungal prophylaxis in preterm.
If the unit incidence is the base incidence of fungal infection is low, definitely no. No routine antifungal prophylaxis.
Please brief again about making antibiotic policy.
Oh God, just 40 minutes talk.
We'll share
There
the
are 6
recording.
steps. You need a local antibiogram. Then you decide which are the most common organisms. For those most common organisms, which drug, either alone or in combination, will cover at least 60% of those organisms, and then choose that as a first line antibiotic. And then which drug combination will have at least cover 90% organisms. That will be the second line. Simple.
That's all I think we have in the questions. If anyone has any more questions, they can either unmute themselves or they can write in the chat box. Indian scenarios facing more non-albicans with routine fluconazole. Will routine fluconazole help?
Will help. Unlikely if you have some intrinsically fluconazole resistant candida. Unlikely. But doesn't means that means of course you cannot use amphotericin as the prophylactic antifungal therapy. Again, the crux is to prevent fungal infections. So prevent infections. So here you prevent fungal infections. So make sure that fungal infections are reduced, and then stop using prophylactic antifungals.
Minocycline.
Nystatin, I do not. In nystatin, yeah, guidelines do recommend nystatin. I have not. We don't use antifungals, prophylactic antifungals definitely, and our use of antifungals is also quite limited. Maybe 2 babies in a year or 3 babies in a year. So I'm not the right person to answer these questions, to be frank.
Minocycline use in neonate.
Yeah, we can. Minocycline definitely as a reserve antibiotic. So last line when everything is resistant, so extremely drug resistant, minocycline can be used. But remember, tigecycline is both IDC guidelines and the European Society guidelines. They do not recommend for bloodstream infections. So tigecycline is for tissue infections. Okay, so T for T. So not for bloodstream infections. I mean, newborns predominantly bloodstream infections. So I would avoid tigecycline. Minocycline specific case scenario, but otherwise not.
In a preterm with mother having candida sepsis, use of fluconazole.
Mother having candida sepsis, I would not, just because mother has candida sepsis, I would use fluconazole in the baby. No, I won't.
Is there method to increase positivity rate of CSF culture?
Yeah, you can inoculate CSF in the blood culture bottle, but the traditional blood culture bottle, the automated blood culture bottle, it is likely to increase, but I'm not aware of the studies that have shown that, but the microbiologists do recommend, okay, send it in that. So I think we have started using it for the last few years, and unfortunately, for the babies, some babies do turn out to be positive. Fortunately for us.
Use of ciprofloxacin and levofloxacin in preterm.
Ciproflox, we do not have a definite long-term studies, but they seem to be at least short-term safe. So yeah, if you can avoid use of third use of cephalosporin or a beta-lactam inhibitor as a first line, maybe you can use ciprofloxacin as first line.
Amount of CSF that is recommended to be sent in the culture bottle.
At least again 0.5 to 1 ml.
Role of tip culture for diagnosis of clepsy.
No tip cultures.
So that's all we have, sir. Thank you so much, sir, for sparing almost 1.5 hours for the session. And I hope most of the DM and DRNB students are going to get benefited with this. Thank you so much, sir. It was a wonderful session. And yes, all are great. Thank you, sir.
Okay.
Good night, sir.